My name is Stephen Kogut. I am a professor with the University of Rhode Island College of Pharmacy. My COBRE project used de-identified data from the Rhode Island Prescription Drug Monitoring Program to examine the extent to which individuals receiving buprenorphine for opioid use disorder also received prescription sedatives like benzodiazepines or prescription stimulants like Adderall, which may increase risks when combined with buprenorphine. I also analyzed pharmacy refill patterns to look at the relationship between the use of these medications and adherence with buprenorphine. In 2019, approximately 6,000 people were identified as receiving at least 2 pharmacy dispensings for buprenorphine from Rhode Island licensed pharmacies. Notably, over 50% of these individuals were between the ages of 35 to 54 years, and around 60% were male. The most commonly prescribed dose of buprenorphine was 16 milligrams per day, and around 70% of people that I studied received the medication for at least 6 months. Approximately 21% of individuals who received buprenorphine also concurrently received a prescription for a benzodiazepine, with 16.5% receiving both prescriptions chronically, which was defined as an overlap of 28 days or more. Around 13% chronically received buprenorphine and prescription stimulants, while 3% of individuals chronically received buprenorphine with sedative hypnotics for insomnia. Compared to individuals who did not receive prescriptions for benzodiazepines, stimulants, or sedative hypnotics, those who continued filling prescriptions for these medications were more likely to continue filling prescriptions for buprenorphine over time. Several insights can be gained from these results. First, a substantial proportion of individuals who were prescribed buprenorphine also concurrently utilized other controlled medications. While most people filled their buprenorphine prescriptions without substantial gaps, younger individuals and those having multiple prescribers were less adherent, suggesting a particular need to address barriers to accessing or continuing with medication among these groups. Lastly, our findings suggest that individuals who are prescribed buprenorphine in combination with other controlled medications were not more likely to disengage from treatment. That being said, this study did not address the risks of overdose outcomes among persons who are prescribed benzodiazepines or other controlled medications. Yet, our findings suggest possibly that for some patients, the use of certain controlled medications to manage symptoms of comorbid conditions may help to promote adherence with buprenorphine. Further research is needed to determine the real-world outcomes of these medication combinations, considering both drug-related harms and potential favorable effects on overdose deaths achieved through buprenorphine treatment adherence.